How you doing, everyone? This is Kento at Kamiyama Physical Therapy. We are in the 4th week of quarantine. Mimi has joined our introduction again. Say hi, Mimi.
Hi, Mimi.
So we just did a medial knee pain webinar. So inside knee pain webinar, hosted by myself and our acupuncture / physical therapist assistant, Danny Burbano. We talked about oh God. We talked about individuals that have pain in the inside knee. We kind of did this webinar because we have a lot of people walking more now and running more now because of the quarantine. So for those that have issues like with the stairs, running, weights, squatting, this is for you. We go through some structural and a little bit of anatomy and how things work. And then I will talk a little bit about into mechanisms and how it works. And we did some Q&A to go into a little bit more deeper concepts. So I hope you enjoy. It seems like Mia enjoys it. So have a good time. Bye.
Bye.
Hi, this is Kento at Kamiyama Physical Therapy. Welcome to our channel. All right, how you doing, everyone? This is Kento at Kamiyama Physical Therapy. We had some recording issues in the beginning of this PowerPoint, so I just kind of want to add or fill in the blank a little bit before I go into the part that we started to record. So the PowerPoint is going to be about medial knee pain, or also known as inside knee pain. We decided to do this PowerPoint because there's more people walking, running, doing more exercise than before because they're quarantined. People are inside more. So to just get out of the house, people are exercising a little bit more. And I'm hearing from people that, I'm having a little more knee pain than usual. So we just kind of wanted to help educate the public or everyone else in regards to this topic. So my acupuncturist or our acupuncturist / physical therapy assistant of more than a decade, Danny Burbano, is going to start us off talking about the anatomy of the knee a little bit, the structure, the ligaments, the meniscus a little bit, along with the muscular anatomy. Along with that, he's going to talk about common postural pattern that is involved with knee pain and a little bit of common movement patterns as well. Once that is all over, once Danny has finished and beautifully explains everything, myself, Kento Kamiyama, is going to come in and talk about more kind of like a show and tell of how different mechanisms can lead to medial knee pain. After that, we go into a little bit of Q&A. We did a little bit of Jeopardy thing. I don't know if it worked well, but I think it was kind of fun for me at least. And then we did go into a little bit of Q&A to go into a little bit of advanced concepts. So during these times, my company, my Danny and myself and my admin also kept on thinking, how can we help everyone else? So the difficult thing right now is to receive care. It's really hard to find doctors that take a look at your care, take a look at you right now, or even physical therapists because everywhere is closed. So we want to figure out a way to see how can we help. So if you're stuck at home, tired of being in pain, let's say you have chronic knee pain, back pain, hip pain, shoulder pain, neck pain, and you want to make sure you feel good once all this is over, because you don't want to be in pain once this is over and you're about to go back to your work or everything goes back to a little bit more normal than before and you're in pain. So to kind of start avoiding that or actually have an idea how to work with that, we want to help. So we have been giving out complimentary virtual sessions right now because it is hard to know if telehealth works. So we just want to give out like complimentary sessions to even see if it works for you guys. So we've been limiting at 10. Last week we had 10, and then a lot has been taken out, so we only have 3 left, and I already have a couple people already suggesting. So for those that kind of want the last spots, please feel free to email us at info@kamiyamapt.com or call us at 201-305-9665. So we're going to get into the knee joint. I'm going to introduce Danny Burbano now. He's an acupuncturist in New York, along with a physical therapy assistant of more than a decade. He is an adjunct professor for the Seton Hall University for the physician assistant program and also the physical therapy program for gross anatomy. So he has a lot of experience. He's great with anatomy. So he's going to go into this part of the PowerPoint in a split second.
All right, so today the topic is going to be, of course, knee joint. And the simple way to understand about knee joint is going to be a hinge joint, meaning if you were to think about a door and the hinges on the door, how they open and close, the knee is going to be similar. meaning that the knee is going to extend and flex. But in addition, the knee also rotates, which we're going to show you later. The knee is divided into two main components, meaning, is someone Okay, everyone check your microphone, making sure it's off. But let's get back on track. So that it's two main components, right? It's going to be the tibiofemoral, which you're going to see here, and the patellofemoral. The tibiofemoral component, which is going to be here, is designed mainly for weight bearing, meaning the weight bearing from your the trunk, the head, and all of that to act as like a cushion, right? Now we have the patellofemoral. That's designed more for force. That's going to make more sense once we get into the muscles, but the patella is going to create that stretch along the quads, which we're going to see in a few minutes. All right, so before we get into the muscles, I wanted to show you a little bit about the ligaments and the meniscus, which is basically the cushion around the knee joint. So let's get into it. So if we see here on the right side, we're going to see a right knee in an anterior view or front view, and the kneecap was taken out. The first thing that we can see here is the meniscus. The meniscus is designed, it's like a cushion designed to deepen the surface. In other words, it's almost like designed to hug the knee, that basically hug the knee or hug the femur against the fibula. The additional feature of it is basically designed to, it's a shock absorber, you can think about it, right? So every time we take a walk, we run, we jump, this meniscus, this middle part in here is going to absorb or take the shock of every step, every jump, right? Because we don't want to have bone against bone, because then that's going to be painful, right? Now, other structures that we can see from here, if we take a look at the slide on the right side, is going to be the medial and lateral collateral ligaments. So this is going to be the medial, and this is going to be the lateral. We also can see the ACL and the PCL. Because we're trying to keep this nice and simple, the main thing about the MCL and the lateral collateral ligament is designed basically to give even more stability to the joint. So what's the main function is going to be, is almost like a hugging. It's almost going to prevent the joint from going to the side, from the outside or inside. It's all going to make sense a little bit later when Kento goes into the mechanics of it, but I just want you to remember this structure. Another interesting fact about this, the medial meniscus, is that it is connected to the medial collateral ligament. This becomes important when it comes to injury, especially for those athletes. So let's say some person, some guy or girl is playing on turf, and their cleats get stuck in the turf, and now they start turning or twisting the other way. What's going to happen is the ACL is going to rupture or tear. But along with the ACL, they're going to have a meniscal and medial collateral tear. What they call is usually unhappy triad, meaning three different structures were torn or broken. That's going to come more like I said, for sports, and what the meaning of it is like, it's going to be a longer rehabilitation period of time. Now that we know a bit about the bones, ligaments, let's get into the muscles. All right. So if we can see from here, we have anterior view or front view and a posterior view on this side, right? The main action of the knee joint is going to be extension, flexion, lateral rotation, and medial rotation. So actually, let me stop sharing for now, because I want you to see something around here. All right, so if you take a look at, I want you to meet Stan, for those of you guys who were here last week. All right, so from here we can see Stan, that if you see the knee joint, right, this is gonna be extension, this is gonna be flexion, external rotation, and internal rotation. As you can see, the rotation will only happen when the knee is bent. When the knee is straight, it will happen from the hip. So as you can see, the hip has a big component for the knee joint. All right, let's go back in here. And I want you guys to see. All right, perfect. So like you see the specific muscles are here. If you guys you guys can take a screenshot, or we can send you guys each muscles, or we can, we don't want to waste time on that. So let's get a little bit into the common symptoms. So how do you know that something is happening around the knee joint, or when things are going wrong, right? So common symptoms from a client is going to be, the client is going to be saying, going to tell you, I have sharp pain or a dull pain. Sometimes that pain also comes with swelling. Sometimes you can see the swelling, sometimes you cannot see the swelling. When you cannot see the swelling, what's happening is like you might feel a warming sensation around the knee joint. Other limitations that come with a chronic knee pain is going to be range of motion limitations, meaning the knee is going to feel stiff. Sometimes it's going to be stiff in the morning. Sometimes it's going to be stiff when we're sitting for a long time, or squatting, or reaching for the floor. Something else that happens when there's a chronic issue is going to be instability, meaning when the person goes up and down the stairs, when they're squatting, when they're reaching down to play with the kids, they're going to feel that knee is collapsing or giving out. So imagine, so if that knee feels like unstable, it's going to be basically going side to side, or it's going to create more and more instability or the friction around the joint, making it more inflamed. All right, so now let's find out those common postural patterns and movement patterns so we can understand this a little bit better. So if we can see here, on the left side, we're going to discuss first the posture patterns, right? If we can imagine on the left side, if we imagine a line going from the top of the head all the way to the bottom of the foot, if we get a straight line in here, we can see that the knees are behind this line. So that's going to show you that hyperextended knee. So you can imagine how much stress is being put out on the posterior forces, on the anterior and anterior, kind of like both anterior and posterior side of the knee, right? Something else that you can see on the right side is a big factor is going to be footwear. So that's with heels, but also with flats, so any kind of shoes that does not give enough support. So if we take a look at this picture on the right side, we see that this woman is wearing heels, and we see that the forces are distributed unevenly. You see that the knee is being stressed out, the hip, the low back, all the way to the knee. And of course, this gets worse as the heels get higher and higher, longer and longer. You can see the effects on the right side. All right, so now let's discuss two more common posture patterns. They're going to be similar to what happened last week with the hip. Is everyone likes to lean on one side, either the right or the left. All right, so if you can see from here, the hips are here and the trunk is somewhere else. So you can see the forces are distributed unevenly. So if this is being overly stretched, you can see how the effect is that it's going to have on the knee. Something else that's being a common pattern that it might look cute on the kids, but it's not so cute when they start growing up, is going to be having toes in or toes out. The main thing to worry about in this pattern is the alignment. So if you to imagine the femur here and the tibia here, you can see how they're misaligned. And you know, like in anything, like in a car or like in anything else in real life, if something is misaligned, it's going to start wearing out. If things start wearing out, things are going to break. So hence the ligaments in here, which we're going to discuss a little bit later. All right, so now that we know posture, let's discuss a little more about movement. So if we take a look at this slide, the common pattern is going to be a collapse. If we want to go into medical terms, it's going to be valgus or varus. If we take a look at the picture, the first one is going to be the proper or the most optimal alignment for the knee. All right. If we take a look at the second one, this is going to be called a varus, meaning the knee is going to go away from midline. All right. So compare here to here. The next pattern is going to be valgus, meaning the knee is going to go in or cave in. This is mostly going to happen when in everyday life, like in going up the stairs or when trying to reach for the floor. And especially if you're working out, you know, every time you do a squat, every time you do a deadlift, you're going to see that that knee is going to go in and out. So this is going to result in knee pain or even something going up the chain like a back pain or like an ankle pain. All right, so this it's gonna make more sense in a few minutes when Kento discusses the motion and the mechanics of it. All right, Kento, I think it's your turn right now.
Thanks, Danny. Can you unshare your screen so I can share mine now? All right, so mute yourself, Danny. So unless you want to say something.
Not now.
All right, cool. All right, guys. Thanks, Danny. So we're gonna go into now. Am I speaking now? Oh, this is go. Yeah. Okay. Cool. All right. So now we're gonna talk about the mechanisms. I'm gonna see if I can create a different light or how to see it a little bit differently why you may have medial knee pain. So I'm gonna share my my PowerPoint real quick, and then I go right back into it. Give me 1 second, guys. Slideshow. All right. So we're gonna go into reasoning behind the knee pain. So these are 3 medial reasons that I'm talking about clinically observed reasonings why you might have medial knee pain. Before we go any further, pain is a very interesting thing. Just because you have medial knee pain does not mean that there's something like always going on with the knee pain or in the knee area, or the cause is not always in the knee pain. A lot of different things might be happening, and it goes up towards your brain and says, hey, there might be like knee pain is affected somehow. I'm gonna present this sensation called knee pain. So I'm gonna talk about certain reasons and why it may lead to knee pain. So Danny has talked about the valgus and varus, where like the knee is separated far apart or knee is going in too much. And I'm gonna talk about how it can lead to medial knee pain. So if you guys can see me here, I have a bone model. Right? So let's talk about for people that have a knock knee, so where the knee goes inwards this way. So if you take a person where the knee goes inwards this way, can you guys see, and I want to see, make sure I can see you guys, some people's reaction. Can you guys see the inside part of the tissue gets stretched? So if you kind of take a look at here, the inside little rubber here gets stretched. And because that area gets stretched all the time, you may sense medial knee pain for some individuals. The important reason I'm talking about this is to understand that the tissue structures in the inside part of the knee right here is being stretched. The reason why I'm talking about this is many times an individual thinks something is tight, right? We sense tension, and doesn't always mean that we need to always stretch it, right? Or massage it all the time. Because by doing so, sometimes because it's already in a stretched position, you keep stretching and it never gets better. All right, so when a person has a knocked knee, the inside tissues of the knee might get overstretched. On the contrary, when an individual has a knee that's open too much, just take a look at what happens to the knee here. If I open so the knee goes outwards this way, this is the right knee, take a look at my inside part of the knee. So this part right here, the inside part gets compressed while this part gets opened, right? But some people may still have pain in the inside of the knee, but with different mechanisms, right? Just because someone has inside knee pain does not mean that you know why you have knee pain until I observe them or someone else assess them and say, hey, what kind of pattern do you present? And why is it leading to this thing called medial knee pain? So for a person that has the knee open, the knee compresses in the inside. When the knee is inwards, the knee decompresses, but the tissues around this area gets overstretched. 2 different mechanisms, but the person might still have inside knee pain. I hope this makes sense, guys. It's always hard to figure out how to look at it. Someone's giving me a thumbs up, so I'm taking it as a good sign. All right, another thing, if you go to number 3 on this PowerPoint, it says increased rotational torque on the tibial femoral structures. What I mean by that is
this area. So Danny kind of explained it beautifully. Our bones here rotate a little bit, not a whole lot. There's not a lot of rotation going on between the two, but there's enough. There's enough. So imagine when someone is, and if you take a look at the structure here, if I over-rotate something, can you see how it stretches the structures here? Or if I over-rotate the other way, it may stretch the other way. So you are supposed to rotate when you bend your knee and extend your knee. You're supposed to go through kind of like an internal rotation, bend, external rotation, coming back up. You're supposed to go through those things. It becomes a problem when it gets stuck in a certain direction and it cannot go the other way. When you see those things, at least for me, when I see them as like when a person comes into my clinic, I'll see how their knee or these shin and hip bones are interacting with each other. And is it stuck in a certain direction, which is this way, or is it just stuck completely there? They don't even rotate. So they rotate all together, which also becomes a problem. So these are different reasonings behind why you may have medial knee pain. Hope this makes sense. If you have questions, feel free to put it in the chat, or if I'm not sharing it well. Oh, sorry. Okay. So what are some things that could influence the mechanism that I just talked about, where the knee opens or knee closes, or the knee rotates too much to one side or the other? I don't want to go into too much detail, but I'm trying to make it simple by saying it's these three things. There could be more, to be honest, but I'm making it simple by saying these are the main three things that I may take a look at. One is feet. So if you try yourself, and if you're standing up, try to kind of collapse your arches completely and see where your knee goes, right? Or try to really arch your feet and see where your knee goes. You should, or hopefully if you do it fairly well, you should see how, as you manipulate your feet, how it affects your knees, right? For those that are not necessarily like into physical therapy or in a rehab world where you're really looking at mechanics. Number two is hips. You've probably seen people where they like to sit in Indian style all the time, where they knees are, I can't show it with my hands, but I hope you guys know what Indian style sitting is, like cross-legged, right? My son always says crisscross applesauce, right? For those that have parents, right? Or they like to kind of bring their knees in all the time, but it's probably because the hip structures, and I'll unshare it real quick, is the hip structures are either overly turned out this way or overly turned this way, or turned in too much or turned out too much. And because if you manipulate here too much, a lot, it will affect how the knee will move. I hope this makes sense, right? So these are some things that I take a look at. One extra thing that you might have not thought about, or you might have thought about, but you didn't see the connection to how it leads to knee pain, is the core. And I'm gonna do my best to explain this because this is a concept that's a little farther away from the knee, but I hope you can get this. So hold on, I'm gonna make myself bigger so I can see my own self. So I know you can see it. Okay, great. So take a look at here. Take a look at here. Let me see. Take a look at here. So the core is above the pelvis, like right here around to the rib cage, right? Depending on which obliques you're talking about, and attachment's a little bit different, but we'll just keep it here. So with a good core, a core is stabilized well. It stabilizes the pelvis and keeps that front part of the pelvis inwards a little bit, or stabilized in. But now imagine, let's say, it's the easiest way for me to kind of analyze or create an analogy is a pregnant woman that's in the third trimester. Your stomach gets overly stretched and this pelvis opens. Now, take a look at what could happen to the knee when this hip kind of comes along with this pelvis. Okay, I'm gonna kind of glue these together with my hand. Watch this. I open my pelvis and see how my knee went inside that way, right? Some people, when this and this is kind of glued together, and I call it like, it's not opposing each other, it goes in, and that could create this nature of a valgus from a core perspective. I hope that makes sense, right? Some other people, and I'm gonna go into harder concepts, so if you don't get it, and Danny's probably gonna yell at me later, but I'm going for it, Danny, sorry about that, is if the person does this all the time, and the hip realizes that it needs to oppose, right? It'll do this, but because it needs to fight so it doesn't go like here, it opens. It constantly opens. If you ever seen people that are really tight in their backs, they tend to open their legs a little bit more, and they're like really tight. They kind of lean back and forth. So their muscles here always get tight, which leads to tension on the outside, right? I hope that makes sense. I just started talking because we're quarantined, so I'm kind of bored at the same time. So I'm just talking, okay, guys? Anyway, any questions thus far? If you do, put it in the chat. I'm going to share my PowerPoint again, unless I have more things to talk about. Oh, okay. So Danny and I were talking yesterday or 2 days ago and say, I kind of want to make it more interactive. So we're doing a quick case study for those that have been listening. We're going to do a quick case study to have you be a little more involved. So let's go through a quick case study. So just to see how much you remember so you can relate to things. We're going to do a case study named Jane. Jane came to our clinic with complaints of right side inside knee pain, so medial knee pain. She presents with knee varus, which means that the knee is opened with a high arched foot, a really, really arched foot. She can't flatten her foot. In our standpoint, they can't pronate the foot very well. She's gone to a doctor. Everything else seems to be fine. MRI and X-ray demonstrates no significant structural deformity. So you have no problem. There's no meniscus, no ACL, no MCL, whatever else is there in the medical world. Everything is fine. So according to the hypothesis that we talked about, right? Jane's, and this is the questions, Jane's right medial knee most likely experiences A, lots of tissue stretching in the inside. Is it tissue stretching? Or B, lots of compression? So I want, oh, no.
You defeat the purpose.
So for those that saw the video, whatever, but I do want to say, for those that's been looking, I want you to put it in the chat, and it's going to be a painful 30 seconds.
They can type it in why. Why do you think that, Kento? Why did
I want you guys to think about it through Jeopardy. All right, that was too painful to my liking. Okay, so the answer is, and I think I gave it away because I don't know how to work this through.
But we can also hear why they think it's B too. That's besides, and now that they saw the answer, right?
The answer is B.
Why? But why is B? Let's hear it.
So
comments, either you guys can either type it or you guys can come live and let's hear the answers.
Yeah, so for those that want to listen to Danny's, it's like pressure there, feel free to answer the question, why you think that is inside knee compression. So all of you are right, that said painful compression, because it's compressed, like, just to review, when the knee goes outwards, it tends to open the outside tissues and it will compress more the inside, right? Just mechanically speaking, it tends to decrease the space in the inside. So we would consider that a compression type. And what we would do is to help decompress that side through different type of exercises, right? I hope that makes sense. Let's go back into the PowerPoint. So the answer was B. Thank you for whoever was participating. Thank you so much. So simple things you can do. As a physical therapist, for me doing a webinar, it's very difficult to tell you what exercises are the best for medial knee pain. Because as you've seen this already, there's different mechanisms on why this could happen. So I'm going to make it very general, very, very general. If the person, and if you took a look at it, if you try to move your arm, someone is, hold on.
And so I think someone has the microphone on. I don't know who it is.
Oh, got it. Who? Lisa. Anyway, so when you do have knee pain, important for you to notice, if you are assessing, is assess your ankle flexibility, right? Can you flatten your foot very well? Meaning, can you pronate, right? If you're technical, can you supinate your foot very well in a good way? right? Can you do those things that help you affect how the knee moves? Or can you actually point the toe down wall, point the toe up? Like, take a look at those things. Because by looking at how your ankle moves and which one's restricted, this may help you how to look at or improve your knee pain or knee symptoms, whatever you may have. The second one is the hip, right? Whenever I look at the knee, it's probably a good idea in general to look at the above and below things, the foot and the hip. So if you're having trouble moving the hip inwards this way or outwards this way, whatever it is, see which part direction feels like it's limited and talk to a healthcare provider. We got a couple of healthcare providers right now in our webinar. Thanks for coming. I mean, I hope you got something out of it. But I know Sean's here. I want to help out Sean too. Sean, I don't know if you're still doing some, I saw your Instagram. You're also giving out some complimentary sessions too. So if you guys have any idea with like any need for a knee, feel free to contact him as well. And feel free to contact us as well, right? Because we're all here to help, right? So please feel free. Feel free to contact us to have any questions. Let's see. So hold on there. So we are going to, good. So Sean has said he's still doing free consults. So feel free to contact him. Sean, I'm going to make you busy, buddy. I know you just started your own thing too. So I'm going to make you busy. I want to be busy too, but you know, talk to Sean as well. We're all here to share. We're sharing the screen here. So basically that was the PowerPoint. If you guys are going through it just like we did with Sean, if you do want to go through some complimentary virtual sessions to understand what's going on with your knee, or you have a friend or family that could use a little bit of assessment and expert advice during this coronavirus time, feel free to contact us through the email at info@kamiyamapt.com or call us at 201-305-9665. So now we're going to go into Q&A. Does anyone have any questions about medial knee or whatever you want to ask about? It'd be preferred if it's about knee stuff. Does anyone have any questions? Oh, I see Jen. Hey, Jen. Look at that. No one has any questions. So no one has ever experienced knee pain before.
Okay. But it's not about me. It's my client, really. But I have a client. You can hear me, right?
I can hear you. Thank you. Go ahead.
I have a client who, like, her right foot, like, is severely pointed out, like, more than I've ever seen in my life. And she sometimes has medial knee pain, but it's not, like, too often. But she also just, like, she's a pretty new client for me. So she probably will have it more when we start actually training more. But she hasn't really exercised a lot, so it's probably why she doesn't have too much pain. Like, what's, like, step one to, like, start helping with it? Like, I don't even know what to do with it.
Danny, do you want to go with this, or do you?
I mean, there's so many ways you can go. You can take a look at the hip, like Kento was saying, or take a look at the ankle. I mean, it's up to you. You can do ground up or top down, right? So you can start looking at strength or the position of if it's the toes are pointing out when they're doing a motion, or put it this way. You can have the patient lay down on their backs, right? And if you can see that the toes are pointing out already, like not doing anything, and then that it gets worse when they're doing a squat or then moving and doing the stairs. So now you know it's something more functional. So you can start looking at kind of at the hip. So let me kind of to make more sense. I think maybe let me share the screen. I think this one. Remember, like when Kento was saying that the rotation of the hips and the alignment of the hips has a big component to the knee. If we take a look at this at the slide, you see that like the quads, some of the quads are starting on the femur, right? But a part of the quads, one of them actually starts around the hip, right? And if you take a look at the other muscles from the back, they also start, the muscles that go all the way down to the knee, they start in the hip. So I will start looking at the hip alignment.
Okay.
You know, like look at how much rotation they have, how much rotation of the hip they have, like how much internal rotation, how much external rotation. and see, you can actually start testing like kind of like, you know, if they're strong enough, if they can hold if they can start to hold the abduction, or, you know, or if they can squeeze their legs. That can kind of like give you more hints of where to go from there.
Okay. Thank you.
You're welcome.
Any questions? Any other questions? So Solana, that was a great question, by the way.
Kento, this is Nicole.
Hi, Nicole.
And hi. And I've worked with you on my medial knee pain on my left side, and it comes and goes still to this day, but not as much. And one thing that I found really interesting that you worked with me on before was that you asked me if it hurt when I was like on the subway, and it did when I sat down, but it wouldn't hurt like when I was on the toilet or in a similar position, same flexion of the knees, same flexion of the hips, but it wasn't hurting in those spaces. It would hurt like when I was on the subway or like in the office. But it didn't hurt when I was like at home on the couch or on the toilet or somewhere else seated. And so that was very interesting for me. And I'm sure there's lots of different reasons why pain's multifaceted, but it was just an interesting observation that even in a similar position, that it was hurting in one space all the time. It always hurt when I was on the subway, but not when I was at home. And then the other thing that I thought was neat was you're talking about the pregnancy thing. My knee feels always better when I'm pregnant. So like when I was pregnant last time, it didn't hurt at all during the whole pregnancy. And I'm sure there's hormones and stuff like that, but just interesting, maybe that position of my leg and the pelvis for some reason took some pressure off or made those ligaments feel, I don't know, different. If it's a ligament issue. But that was interesting, pretty fascinating.
Yeah, that's a great call. Do you want me to comment on those two, or
feel free. I mean, I'd like you to comment.
It's up to you. I can, you know.
Go. Yeah.
If you ask me to be quiet, I've learned myself.
I don't want you to be quiet.
So let's talk about the first one. So when it hurts on the subway versus like at home, you might be in a very similar position, but you don't hurt when you are at home.
Right.
So the one thing that is different between those two is, let's talk, and this is more of a speculation and hypothesis, is one is a moving object that you're on, right? A little bit more, you know, like more relatively close. Like we're still moving, like the earth is still moving, but you know, it's a much bigger thing. All right. So at home, you're not. So the difference with that is there's a reference that's stronger. Like you can sense there's something that's not moving. So the brain knows where you are. When you're in the train, it's less of that.
Right.
So technically, in those positions, you might have to work more in a subway in order to feel more balance. Like you never feel more balance in a subway, right? You're always kind of doing that, right? So when you can't adapt as well during those times, that means you might need to have more sensory input into those knees, hips, core, when there is a less stable thing. Does that make sense?
That makes a lot of sense.
Right?
Yeah.
In a sense, you have, in a way, it just tells you, hey, you need to work on more somatosensory, meaning you need to learn more proprioception, kinesthetic awareness in those areas, if we're just talking about those two contexts.
Right. That makes sense.
Does that help?
Yep.
Right. That's another way to look at it. The pregnancy thing, that, I mean, there's so much. I mean, I have a lot of thoughts on that. Of the hormone thing, I think just helps you with it as well. Like you're a little more flexible in your ligaments. Right. But also, I'm thinking from a pressure perspective. When you have, you know, your baby, you have more pressure into your abdominals.
Right.
Right. So your abdominals too are maximally getting challenged at the same time. Right. So not that I ever was pregnant, right, or ever will be, but you feel the pressure into your stomach, right? So that also gives you the sensation of intra-abdominal pressure.
That makes sense.
Right, and that may give you the reasonings behind why you don't feel as much knee pain, because you can sense things more.
That's, yeah, and I can see the connection between that and the subway one too. That's awesome.
Yeah. So it's just a different reasoning. It's a little more complex than we just talked about.
No, it makes total sense.
I hope that makes sense.
Thank you so much, Kento. That was fantastic.
Of course. Any other questions?
Yeah, I have a question.
Preston.
How's it going, Kento?
I'm good.
So with clients, sometimes we'll use heel elevation to improve squat depth or form because it's just a quick fix and it gets them going with minimal coaching. But Is that a short-term strategy that we want to eventually transition into them not having that heel elevation anymore and being able to do that squat without that assistance?
Yeah, it's a great question. It really depends. Well, I think you already know the answer, what you just said, right? The answer was within the question that you already asked about. So if you are elevating the knee, elevating the heel, it will make it easier to squat, inevitably, right? Just because the ankle range of motion is less, and also the heel or the ground came closer to the heel, so it's easier to be more upright in that position. Right? So that's one thing. But if you are trying to squat with them, let's say you are trying to give them an Olympic lifting squat or powerlifting squat, or they just want to learn how to squat when they are gardening, then you probably eventually want them to take it away. Right? For me, it depends on the intention of what you want.
Got it. Yeah, I guess my question was, what are the consequences of excessive heel elevated squats? And I think I already got the answer in my head, but I just wanted to hear that explanation.
Yeah, you're looking for validation, buddy. So basically, the consequences is you forget how to do a squat with the heels down. Like that's as simple as it is. What may happen is your quads may activate more because your heels are up, right? And you can manage the pelvis and ribcage pressure, but it becomes a crutch. If you keep using something to support to get to the same spot, eventually becomes a crutch. Imagine your parents holding your hand all the time, right? You eventually lean on that, rely on that. So how are you going to progress? You have to challenge it once in a while, but just know where they are at so you can progress them depending how much you want to.
Got it. Thank you.
These are good questions, guys. What else? Tenshi raises the hand just like a Japanese guy. Please go for it.
So when I have both legs. Like when I keep my ankles together and I straighten my knees, like there's like probably like a fist width of like gap between my knees. And I've been studying and like practicing PRI, and you talk about like sensing the right arch. And I was curious, like I have a really hard time feeling my right arch. And I was wondering if the bow-leggedness affects pronation and your ability to feel the arch or not.
Very specific, Tenshi. That's very specific. So I can't see to be honest, I'm not sure if I remember the specific picture of what your knee does and foot does. Is your foot flat, Tenshi?
No.
So, okay, great. So same thing. This is a hypothesis, right? So if you guys can, if you're interested in demonstrating yourself, when you bring your knee open, when you open up your knee more, you're going to put more weight on the outside part of the foot, right? So you're going to have more easier ability to arch the foot, if that makes sense, without the help of the arch. What I'm saying is your hips are doing it for you, or knee position is arching it for you. So why would you feel the arch when someone else is doing it for you already?
I got lost.
I'll show it to you. Give me 1 second. I just gotta adjust my place. Hold on. Tenshi, can you see my feet and legs?
Yes.
Okay. So I'm not gonna do anything to my arch right now. I'm not gonna do anything, but I'm gonna just open my knees. See how I create an arch?
Yeah.
But I didn't have to do anything to my arch muscles to get there. Right? So why would I feel my arch? My arch muscle has to work to feel the arch, in a sense.
In other words, it's a passive arch. It's not an active arch. That's what it means. Basically, each arch is just created. It's an effect of something else. But the muscles that create the arch are not actively doing or not actively firing. That's why, as much as you wanna concentrate on it, it's just because the body will always do whatever is easiest. So if something
Right.
is already in that position, what would fire? There's no need to fire anything else around the foot because it's already there. Just think about active versus passive.
Right.
Hmm.
So and this is just a hypothesis, Tenshi, we just have to kind of speculate. If you want to start allowing the arch to work independently from your hips or knees, what I might suggest is bring the thigh or the knee inwards a little bit, or over the heel or inside of the heel, and then try to arch when the body weight is trying to push you into pronation.
So when they say feel the right arch, you're trying to actively create an arch.
Who's they?
And when they mention that
Who's they?
in PRI,
Okay. Go ahead, keep going.
so when PRI says feel the right arch, they're saying to create an arch under the right foot. Is that
So
what they mean by that?
I'm not going to speak for PRI right now because that's not what I'm trying to do.
Right.
But in this current case, what I'm talking about for you is, can you feel the arch when it's activated?
Like,
if I'm giving what I believe PRI is trying to tell you in this current case is they're trying to pronate your feet. So the foot has to pronate to feel the arch on the ground.
mm-hmm.
This is what I believe PRI is discussing about when you're discussing about left AICs and all that, right? But I'm talking about entirely different things right now for you in order for you to feel the arch. Because if your knees are open, you're going to give a passive, like Danny said beautifully, a passive arch, right? So in order for your arch to start actually working, I'm trying to tell you to bring your knees in a little bit and then arch to see if it does help.
Okay.
It needs a challenge. Other questions? Let's go with one more. Yep. Anyone else? Anyone else? All right. Danny, any lasting words?
I think in just like for like we always emphasize, right, about treating the whole body, right? Whenever someone comes with knee pain, make sure you look above and below, right? Make sure you're looking at the hip. Make sure you're looking at the ankle, how much ankle is moving, if it's moving too much or not moving at all, or if the hip is moving too much or not moving at all. So make sure you guys remember that.
All right. I think we're at like 50-minute mark. So I hope this was helpful, guys. So we're going to keep going until I get sick of doing it every week, I would say. So next week I'm going to selfishly talk about shoulders. However, is there anything that you want to learn about shoulders that you want to suggest so I can just prepare that way? Does anyone have any suggestions about shoulders?
You guys can type it or say it.
Yeah, Mark, you look like you're in Hawaii. Do you have any suggestions from Hawaii?
Right shoulder pain, please.
Right.
Oh, that's specific.
Shoulder pain.
Very, very specific to Mark's specific pain, it seems like. Anyone else? Right shoulder pain is very general. I need a little more specific if you guys have any.
When I see you Thursday, I'll show you.
Fine.
Oh, I can make him wait?
Yes, I'm making him wait.
Oh my God, it's a ghost. All right, I'm gonna pick one, guys. I'm gonna pick one. So I would say just it will be a surprise, and we'll do it at the same time, 2:00 on Tuesday. I hope you guys are getting something out of it. If anything, it just helps me, pass the time, so I don't have to always be with the kids all the time. I love my kids, by the way, but it just helps me be an adult for like an hour. So thanks, guys. Danny, so I'll see you guys on Tuesday at 2 a.m. Just look for your 2 p.m., not 2 a.m., 2 p.m. And I'll see you guys next week.
See you guys next week.
Thank you.
Thanks for watching this video. If you found that helpful, and if you now are thinking that I wonder what else this person can help me with, please go to our website at www.kamiyamapeach.com and find other free contents or apply to our free discovery visits to further see if we can help you. For any further information, please email us at info@kamiyamapt.com. Thank you so much.